on from radiopharmaceuticals, there are also some newer, interesting targets beyond radiopharmaceuticals. What are your thoughts about immunotherapy in prostate cancer?
I was wondering when that question is going to come. It's making its way up, especially after we do in my practice, next-generation sequencing based on the results. So certainly has a role late in the later lines. I haven't, incorporated in upfront, but later lines.
Certainly, we've seen, really good responses in the appropriate patients that have the appropriate NGS findings.
Yeah, I feel like the patient population that it might benefit is pretty small right now, but maybe with combination or knowing the best biomarkers and when to use it, we'll have a better sense in the future.
Yeah, I think these are great points, and I absolutely agree that at the moment, the patient population where it is likely to benefit is really small. The patients who have, mismatch repair deficits or high TMB greater than 10, and I think the more interesting part of immunotherapy is moving beyond these PD-1s and PD-L1 inhibitors. It's really, these bispecific T-cell engagers or these bispecific antibodies which can, target immune system in a different way. Are you running any active trials in this space, or have you seen any patient getting treatment with these newer T-cell engagers?
No, we're not right now. I'm
not
familiar
yet.
with it. We're mostly in the PARP inhibitor space right now for trials, but yeah, but
Not yet, not that we can recollect. Yes.
It'll be interesting to see what the survival data is, when it comes out, or and the potential benefits of it. And then also, how does it compare to other BiTE therapies and other cancer groups as far as, the CRS and different toxicities and chronic immune suppression. But
yeah, I mean, these are great points. I think there's early data from T-cell engagers in the context of different tumor-specific antigens. Regardless of whether you think about STEAP1, DLL3, I think the benefit we're seeing is modest. But I think that's partly also the fact that we're using these drugs so late in the prostate cancer course, where they've already used most of, taxanes, RPs, visceral metastases. So maybe if they're used somewhat earlier in the prostate cancer state, we may be seeing better results. I think there's also interesting targets with AR degraders in this space. So truly, I think exciting time for our patients with, even with castration-resistant disease, which is really considered, a bad prognostic sign for these patients.
yeah.
I think this was a very insightful discussion, and I just want to close the discussion by getting your overall thoughts on management of CRPC. How do you suggest we think about sequencing, and any takeaways from the management of castration-resistant prostate cancer in the metastatic state?
Yeah. I mean, from my standpoint, I just want to put a plug in for lifestyle medicine, exercise, nutrition, and just the importance of that for every cancer type, particularly with prostate cancer. We have a lot of studies. Just simply walking 30 minutes a day shows better response rates and slower growth of prostate cancer. So bringing in that lifestyle is always very important. But then also just looking at all your options, molecular studies, comorbidities, trying to give the patient a good realistic view of what to expect, and what are the potentials that we can offer, so that they can have a good shared decision making.
Yeah, I think, apart from those very rare transformers where there's a very aggressive transformation, most patients been practicing more than a decade and a half. We had options. We have more options. It's even though it's castrate resistance, widespread disease, there's still options, and multiple lines of therapies, tolerable ones too. Now with Riaz, definitely is very exciting times we're in, and I'm sure it's going to be only getting better from here. I'm very happy for my patients, and with the available, like as I said, our armor is filled, getting filled with more and more options in it. So.
I think it's an exciting time to be in GU oncology because we've got so many new treatment options coming. The era of single agent ADT, I think, is largely gone for most patients, although there's a subgroup where that's still very relevant. And I think it's exciting to have just an ever-enlarging armatorium to approach each patient with individualized care.
Yeah, I think this is fantastic. I think the key takeaways from discussion seem to be that there are multiple life-prolonging agents. We should make sure that patients receive as many life-prolonging agents as possible. I think then there are tools that can help us decide sequencing, although there is no perfect sequence, but there are tools which can help us, strategize which treatment to come first and which to come later. Make sure that we're still using the bone strengthening agents in CRPC state with bone metastases. And finally, I think we need to think about clinical trials so that we can keep bringing new treatment options for our patients.
Great.
Gentlemen, thank you very much.
Thanks so much.